So now this is going to be a really general lecture. It's going to be a big synthesis of all the pathologies that we've overviewed for the GI tract. So the first one was the obstructive jaundice. Remember, how did this occur? What was the overlying factor causing obstructive jaundice? Remember, that's when the bile ducts are obstructed, and so bile can't flow out into the duodenum. And so this is the clinical picture is always the same. What was the clinical picture here? Remember, you get the pale stool because you don't have bile in the intestines, so it doesn't go into the feces. You have the dark urine because the bile is getting absorbed into the blood instead, and it's going to the kidneys and becoming urine. And finally, you have pruritus because you get the deposition of bile acids into the skin, and that causes itchiness. And of course, you have jaundice because of the super high levels of bilirubin that deposits in the skin. So now this occurs in pathologies that lead to obstruction of bile ducts. So that's can be anything from the pancreatic cancers to the biliary tract diseases to different causes of jaundice such as hepatitis, cirrhosis. Now the other one I want to talk about is obstructive liver disease. This one's different. This one's more obstruction in the venous outflow, okay? And that's going to lead to portal hypertension because if it's not draining well into the hepatic veins, there's going to be increased pressure in the portal veins. And so what happens here? Remember that the flow is going to be diverted into the collateral vessels where it anastomosis with the systemic veins. And then so you're going to get the varices. What were the varices? You're going to get the esophageal varices, the caput medusa, and the umbilicus, and you're going to get the internal hemorrhoids. The other thing that's going to happen in the obstructive liver disease is, well, it's going to be your liver is going to expand because there's going to be all this extra blood in there, and there's going to be increased pressure in these veins. So the fluid's going to leak out into the peritoneum. You're going to get ascites, and then it's going to be painful. It's going to be obstructed. It's going to be distended. It's going to be painful. So next thing I want to talk about is acute versus chronic failure. So we have acute failure of the pancreas, of the liver, you can even draw relations to the kidney, and these all have very specific acute symptoms, okay? However, chronic disease is more associated with loss of function of the organ. So we see that in chronic liver disease, which we call cirrhosis, or in chronic pancreatitis, where you have pancreatic insufficiency. All the same thing for chronic renal failure. You just have failure of what the organ normally does. And I just want to draw another parallel in that cirrhosis and chronic pancreatitis both arise from chronic inflammation that leads to fibrosis and then impairment of the organ function, okay? Remember, the cirrhosis, you have toxic insults, you have inflammatory insults, you have metabolic insults, and all of that leads to inflammation and fibrosis and decreased organ function. And in chronic pancreatitis, the same thing. You get either the chronic alcohol abuse or you have the cystic fibrosis that blocks up the ducts, you get inflammation and damage, and then impairment of organ function. So these are all just very big picture things. Now I want to talk about different parts of the GI tract. Actually, this is a more very general thing. Obstruction of ducts, we talk about this a lot. Obstruction of ducts lead to either both or either one of either increased pressure because the duct's obstructed, and you get compression of vessels, and then ischemia, okay? And then ischemia leads to necrosis and inflammation. The other thing that happens with obstruction of ducts, which we talked about, that leads to infection, do you remember what that was? Remember, that was where the fluid there's stasis of the fluid that the duct normally secretes because the fluid can't leave. And then it's going to become like a swamp, and the bacteria is going to overgrow there, and it's going to cause infection and inflammation. So you see this over again, from the salivary gland stones causing the salivary gland infection to gallstones causing cholecystitis, ascending cholangitis. You can have appendicitis from the fecalith. You can have tumors causing this. So you see this over and over again from obstruction of ducts. So now to specific parts of the body. We're going to look at the esophagus. A couple of general things I want to talk about. Dysphagia. Remember, dysphagia was difficulty swallowing. And what can cause dysphagia? So the first thing you can think about is obstruction can cause difficulty swallowing. The other thing is just decreased esophageal motility. Okay, so the difference is that motility will have a solid liquid dysphagia. That means they have trouble swallowing both solids and liquids. Okay, and that's because liquids normally you would think would be able to flow down, but if the esophagus can't propel it down, then it's not going to flow, and you're going to have trouble swallowing both liquids and solids. Obstruction usually only starts with solid dysphagia because the liquids can just flow around the obstruction. However, if your obstruction worsens, example, in esophageal cancer and complete obstruction, then you're going to get progressed to solid liquid dysphagia. Okay? So next is the stomach. The stomach is, I think one of the main things we talk about here is gastritis and ulcers. And then the key thing here is the balance between the mucosal defense versus the acid. Okay? Because that's how these develop, and you have to understand. If you understand the mucosal defenses and acid production, you're going to understand how these develop very easily. Now, just remember that the symptoms here are very vague. Just abdominal pain, weight loss, nausea, vomiting. A lot of different pathologies in the GI tract can cause this. So the key is the differentiating features here. So like the pain is better or worse with eating, and I can tell you whether it's a gastric ulcer, duodenal ulcer, things like that. Next, small bowel. Small bowel, I think just think about the things that will be present based on pathology. Is there going to be any nutrient problems, nutrient deficiencies? Is there going to be any blood? Is there going to be constipation or diarrhea? And a lot of times you can just figure out the symptoms as long as you understand the disease. You don't have to memorize them necessarily. Now going to the gallbladder, I think gallbladder is just really understanding the anatomy of the bile ducts, because gallstone lodging in the cystic duct can either cause biliary colic or cholecystitis, but then once it enters the common bile duct, then that's a totally different disease. That's either choledocholitis or sanine cholangitis, and then it can go further down, and then where the pancreatic ducts are, and then you're going to have pancreatitis. So just understanding those gallstones and all those ducts that it can get stuck in. And then pancreas, I just want to point out the thing again. They all have presentations of epigastric back pain, either acute pancreatitis, chronic pancreatitis, pancreatic carcinoma. All have epigastric back pain epigastric pain in the abdomen that radiates to the back. Also, just think about loss of exocrine and endocrine functions, and then you'll be pretty good. All right, so that's our big picture overview of GI pathology. I think it just helps you understand what's going on in a zoomed out fashion a little more. All right, next is embryology.